Hello, everyone. Thank you for joining this session about the GDT, the guided dollar class therapy. This is a refresh about the GDT that we propose you today. Just a quick introduction concerning myself. My name is Mary-Christine Collette. I'm an education specialist representing the Swiss Dollar Class Academy, which is the organization in charge of training programs that we offer worldwide to practitioners eager to know more about GDT, about guided dollar class therapy, using different techniques, including high power laser and shockwave therapy. We are welcoming today one of our GDT experts who is based in the UK, Daniel Morgan. Danny, thank you for being with us today.
My pleasure.
Daniel is a sports chiropractor based in Port Talbot in Wales, in the UK, and he will be sharing his expertise today and provide you with a refresh about the GDT. Just a few technical points before starting this webinar. As you can see on your screen, you have a Q&A and chat icons on your screen. Please feel free to use them to ask your questions, anything you think would be useful for your daily practice, and we'll be able to answer them during this webinar. So that was the quick introduction. So off you go, Danny, if you want to start. The floor is yours.
Yeah, no problem. Thank you. Let me just try and, I need to get rid of something on the screen for a minute. I have the chat box open. There we go.
So I will switch off my camera so you have the whole network for you. Just
brilliant.
But
Thank you.
In case you need me, I'm here. I'm just behind.
All right. Superb. Thank you, MC.
Thank you.
So as MC said there, I'm Daniel. I'm a chiropractor from South Wales, and I've been kind of using the GDT now since its development stages. And I've obviously, prior to that, we were just using shockwave therapy in the clinic as well. So I was actually involved with the process with EMS to produce this new concept, and that's kind of, I think, maybe really exciting to introduce into clinic. But what we'll do first, we'll get into all of that as talk goes on. But here is a little disclaimer. This is predominantly from EMS. Training handout is intended to provide medical specialists with information regarding the Swiss dollar class therapy. And it's, as it says, it's a new treatment concept based on the combination of therapies, which would include shockwave therapy, focused radial, as well as then introducing the new high-powered laser, which is just over my shoulder. Although this has obviously been reviewed by all the specialists and experts, EMS as a company cannot guarantee that the material is current, complete, accurate, or contains information that is consistent with acceptable professional practice. So essentially what we want to do is provide you with the information, and then you guys can use that how you feel necessary. Obviously the big one is that this material does not constitute medical or legal advice and should not be relied on as such, okay? So firstly, just welcome you to the Swiss Dollar Class Academy. This is educating tomorrow's experts today, essentially. And the Swiss Dollar Class Academy offers high quality, tailored training programs, well, as MC said, and the SDCA allows practitioners to keep up to date with the latest treatment modalities, indications, and clinical evidence. And we, as trainers, always try to keep up to date with every new study that comes out, and we try to introduce these into our presentations, and just to even be aware of that when we're discussing things. So the SDCA will hold over 200 courses a year worldwide, and we have up to 80 trainers, official trainers, in 30 different countries. And this has led to over 5,000 certified practitioners in over 30 countries worldwide as well. So we essentially want to provide you with expertise, so clinical evidence, We will then give you the excellence and certificate, which would be a training model. And then we will try to get a network of people, which will be the exchange element of that. So you can also register your practice, which will increase your exposure online. So if anybody is looking for somebody who carries out GDT or uses shockwave therapy or laser therapy, specifically EMS, you can go onto the Dollar Class website and you can search for a practitioner and you can get yourself registered on that page. And that's quite nice. And also for us, we've done events in the UK recently where we've kind of been looking for patients to find their nearest source of shockwave or high-powered laser, and we will list that. We go to the website, we put in their postcode, and we find out where they're practicing. And that's quite useful for us when we're going around, so it's good for referrals, but it's also very good for you guys just to get some exposure to the general public. Okay, so quick introduction to GDT here, and it's 6 steps with one goal, and that is pain-free patients. So the GDT is a new treatment concept, and it's based on a holistic approach, combining therapies, which is essentially trying to treat up to 90% of their patients suffering from musculoskeletal disorders. So treating patients has never been easier with this. I think certainly from a clinical perspective, I'm finding using the laser regularly and using that alongside the shockwaves, it really does seem to add a little bit something to the treatment, which we will discuss as well. And there is a specific something that it really adds, and we'll talk about that as we go through. But just to kind of run you through these initial phases, is the first phase we will always assess the patient, and this is something that you should do in clinical practice anyway. Then if we find that it's the diagnosis is something that can be helped with GDT, then we would go on to the Dollar Class high power laser, and we would use this initially at stage 2. Then stage 3 and stage 4 are kind of combined together. And we don't use radial shockwaves and focus shockwaves. So don't worry if you haven't got one or the other, you only would use one of them. So you would say, okay, we're going to use the high powered laser, and then we'll follow that up with radial shockwave therapy. We would then obviously move on to the appropriate rehabilitation and then follow up, which could be however you decide to do that in clinic. We could use it if it's an Achilles, for example, we could use a Visa A questionnaire, and we can see how those patients are developing over your treatment protocols. We can obviously then look at them and see just how their post-treatment assessment differs to their pre-treatment assessment. See if their range of motion is increased with less pain, see if their pain has decreased during activity. So that's the idea here, is that we can reinforce a positive outcome to patients. And that's what we really want to do. So the clinical effects of GDT, we know that there's an immediate kind of pain relief perspective, and this is with shockwave therapy. And this is actually enhanced with the GDT, with the high-powered laser. So the laser specifically will inhibit on the site of injury the nociceptors responsible for transmission of the pain. So that is going to be essentially your C nerve fibers. You can activate your C nerve fibers, with the shockwave therapy. And this acts as a little bit of a reduction in the laser. Essentially is there to reduce down the painful sensation. So the idea with the laser, the long and short is that we can provide a stimulus to the area. It reduces the nociceptors, and that means that we can put more energy into the tissue. And what we know from shockwave is the more energy we put into the tissue, the better the outcomes. So shockwave therapy will activate the C fibers and ultimately reduce the amount of the amount in the injured substance P at the injured tissues, as well as at the spinal cord. So it reduces kind of neurogenic inflammatory response, as well as that localized kind of effect on the neurological system. There is a reduction of pain. So there is research that would suggest that the laser is responsible for a decrease in the amount of prostaglandin E2 and fatty acid, which is a fatty acid responsible for mediating the acute inflammation, and thus reducing the redness and swelling in injured tissues. So essentially the way that we could look at that, if we were using laser as a standalone treatment, which is possible, that would be in your acute phase of care. That would be something that is happened in the last week or 2 weeks. Shockwave, as we know, it tends to be more of a chronic case or subacute chronic cases. With the introduction of the laser, it means that we can actually treat these things a little bit sooner as well. But obviously, shockwave leads to a reduction in the release of the injured tissues and spinal cord of substance P, which is responsible for mediating the neurogenic response. So that's the inflammatory response that we would say from a pain relief. Obviously, we can have an effect on the muscle and tissue repairs, tendon repairs, so it stimulates tendon remodeling. There's evidence as well with cartilage repair. So promotes the proliferation and self-renewal of mesenchymal stem cells, which prevents cartilage from degrading and accelerates its repair process. Now, some cartilage doesn't necessarily repair very well. So if we can, in osteoarthritis changes, for example, then we can try and prevent that further degradation, then that will be extremely beneficial. And obviously there is recent evidence as well to say that the bone repair changes, so upregulate the expression of BMP, so the bone morphogenic protein, a growth factor that stimulates bone healing, as well as then the osteoclast turnover. So that's the clinical effects as a summary, and here are the references for that should you need them. So, as I said, we are able to use the high-powered laser in isolation, as we are allowed to use shockwave in isolation and have been doing so for a number of years. So this is just a list of indications that is covered by high-power laser on its own. So we have an abundance of diagnoses here that is possible to treat. Rotator cuff tendinopathy, glenohumeral arthritis, ACJ arthritis, and I actually used the laser on an AC joint this morning. You get subacromial subdeltoid bursitis, and you can have just general kind of arthropathies and tenosynovitis. So these tend to be these acute inflammatory responses that work really well. And the idea here is that we want to reduce down the inflammatory response. The thing that we found in clinic, and generally the plan of management with this would be, we would see them maybe 3 times a week for 4 weeks. So this could be 12 sessions. This is what I kind of do in clinic with these acute cases. We see maybe 12 sessions over a 4-week period. And again, from a business perspective, that's up to you how you work that, how you model that. But that's kind of the protocol that we would use, is 3 times a week for 4 weeks, so 10, 12, maybe a little bit more, up to 15, 16 sessions. It's a painless process as well, so it's not like shockwave in that sense where we have to try to kind of twist people's arm to come back in. This is a painless process. It's quite effective for those acute cases. So really, really useful in those cases. And I think from an acute setting, this is obviously the difference to the shockwave. Obviously, shockwave would be significantly chronic, normally 3 months, 6 months, and this is predominantly in those early weeks. That's pretty much it there. Now, indications by shockwave therapy, we're mostly all used to this now, but very good with tendinopathies, adhesive capsulitis, trigger points, myofascial pain syndromes, acute and chronic muscle aches, so DOMS, delayed onset muscle. A big study, well, not recently, in the last year or so, that was essentially looking at the increased recovery times for muscle injuries in sport compared to X-Strand study, which is a big study looking at UEFA average recovery in footballers at UEFA Champions League level or European leagues. And basically it was saying that the use of shockwave reduce or increase your recovery time by up to 50%, depending on the grading of injury, which is quite useful. We obviously have superficial non-union stress fractures and Osgood-Schlatter's disease. Now, Osgood-Schlatter's disease is one of these special cases because it tends to be around the growth plates, but we tend to avoid the obviously growth plates typically, and a direct contraindication is if a patient is under 18. Now, with Osgood-Schlatter's disease, it typically will affect 13, 14-year-olds, or normally overactive children. So the difference here is that there's actually been research to say that this is safe and effective for Osgood-Schlatter's disease. So that's why we have painful exostosis, so heel spurs, Haglund's deformities, osteoarthritis, as I said earlier, And Dupuytren contractures, plantar fibromatosis, so lederhosen disease, and also we have Peyronie's disease in there as well, which is a little bit outside the musculoskeletal kind of range, but still it's effective. Spasticity is really interesting for cerebral spasticity and post-stroke spasticity. Works really well there. Then you have skin diseases then, such as acute and chronic soft tissue wound healing, cellulite reduction, scar tissue formation. There's also some research in burn scars. It's, again, the outcome of that is more research is needed, but there's some interest in this now. And lymphedema as well, lymphedema reduction, and that could be secondary to cancers, that could be just generally primary lymphedema or secondary lymphedemas, but very useful for a range of things with shockwave therapy. And then obviously we have the Pisa class, which is focus shockwaves. And this tends to be useful in those stubborn, really recalcitrant tendinopathies, the ones that are just not responding, and you've shockwaved, you put your radial shockwave through it 6 times, and it's just not getting better. And the reason that focus comes into its own here is that we can provide more energy, significantly more energy with focus shockwave than we can with just the radial devices. But again, these tend to be your more stubborn tendinopathies, so your subacromial pain, your calcifying tendinosis or tendinopathies, lateral epicondylitis, on the kind of the medial epicondylitis, medial tibial stress syndrome, Achilles tendinopathies, plantar fasciopathies, pseudoarthrosis, and chronic painful muscular hardening. So just trigger points, etc. So again, these are your indications if you wanted to use them in sole kind of isolation in a sense. So these are your standalone treatments. And in a nutshell, what is high-powered laser used for? It's for your superficial and deep indications, but it's ideal for your acute phase. And it should be your first choice to address pain and acute inflammatory in any MSK disorder, really. Then we have superficial or deep indications, subacute to chronic pathologies. First choice for your calcaneal tendinopathies, enthesopathies, all your tendinopathies, in my opinion, as well as some spastic tissues, which is going to be secondary then to your strokes and cerebral palsies, etc. And then we have focus shockwave, and this is for superficial or deep indications again. There's a way that you can manage it so that you can, whereas if we change kind of energy in the radial, it means that it will travel a little bit deeper into the tissue. Kind of with this, we can change it so that if we put a larger silicone head onto the focus, it means that it'll be more superficial. If we do a smaller, thinner silicone head, it means it'll go deeper into the tissue. And I'll explain that when we get into the focus section. But it should be your first choice for this calcified lesion, so for your calcific tendinosis, tendinopathies. And those, I also find that if shockwave therapy has failed, so if your radial has failed and they're not responding, which is very rare, but if they haven't responded in those cases, focus may be an option for you there. So it's worth considering. Now, this is the GDT, how we would use this in combination. So step 1, we would obviously use the high-powered laser initially. And this is a custom protocol on the machine, and it's just 3 minutes. So what you find is, depending on your target, your goal within laser, if you have anti-edema or if you want to do anti-inflammatory, then these have individual indications and settings on the machine. So you can just press that and you go, but they tend to be up to 29 minutes, maybe they range from 12 to 29 to 30 minutes. Now, the GDT protocol is 3 minutes, and there's a reason behind that. It's essentially, it's a 905, so everything to do with this laser, it's a 905 nanometer wavelength, and it inhibits nociception. And from a perspective, that provides a strong analgesic effect, which kicks in about 5 minutes after the end of that laser treatment. And that can last up to 72 hours. So that can give you that immediate, like, wow, that feels better pain. But obviously as well, there is that anti-inflammatory element to it, which we spoke about with the reduction in prostaglandin E2. And this is that acute inflammatory markers, and we want to try to reduce that down. So this will then decrease the acute inflammatory inflammation, which can kick in after about an hour after the laser. So the idea here is that if we want just that analgesic effect, we can wait for 5 minutes after the laser and then we can provide shockwave therapy. But if we want to get analgesic and anti-inflammatory, then we wait for an hour. And that's where that kind of wait 1 hour or 5 minute section comes in over into the left-hand side of the screen. So there is some preliminary research that is out there and that is discussing kind of the effects of this. And it's just that essentially we can get significantly more energy into the tissue if we wait 5 minutes or 1 hour. And this is something that we did on the course in Glasgow on Saturday. Me and MC were talking about this just before we started recording. And there was, we had a gentleman on the course that could only tolerate 1.1 bar on his elbow with the new radial device. We provided 3 minutes of laser and we then brought him back an hour later after lunch, essentially. And he then was able to tolerate 2.5 bar onto his lateral epicondyle for his tennis elbow. So he was quite a hypersensitive patient and it was able for us to get that little bit more energy into step 2. So again, this step 2 would be your shockwave, and that is radial or your piezo-class, you're focused. And essentially what we're trying to do here is the same response that we would usually have from shockwave therapy. So prolonged activation of the C nerve fibers induces a decrease in substance P. So we can inhibit the C nerve fibers a little bit. We get expression of the growth factors. So we get vascular endothelial growth factor. We get eNOS changes. We can get the stimulation of the mesenchyme and stem cells. So we get these multitude of effects and a cascade of events that happen. There's an analgesic effect. There is angiogenesis, so the kind of trying to promote a new blood supply and increase the healing responses. We try to get a little bit more of homeostasis within the tendon, and all of these then gives you that immediate wow response. And that is actually one of the things that recent research has highlighted as a predictive factor for patients as they come out of treatment. So after that first session, if they stand up and they go, oh, that feels so much better, that is a good sign that they're going to do well throughout that treatment. So the high-powered laser. The idea is that we just apply for 3 minutes and we are able to get people pain-free, or certainly more tolerable to pain, within 5 minutes. That acute inflammatory response happens after an hour, but all of this can occur within that first session. It's suitable for patients suffering from acute phase of pathology, so in your immediate injury stages, and that's quite useful for, and this is also useful for your ankle ligaments, you know, all of those type of different injuries that we would have. And the idea is as well that it can ease your practice workflow. Now, that means because it's got the arm on with the laser can attach in, then actually it means you don't have to be with that patient. You can do your notes, you can go and see another patient, you can leave, as long as it's set up correctly and you're happy and that they have the safety equipment and that there's no chance that it could go wrong and you're happy to leave them in the room. That is something that is doable. I tend not to, I always stay with my patients, I would say that, just only because I actually quite like to use it manually so we can get a little bit of movement around the area as well. But that isn't absolutely necessary. You can use the arm, you can leave it on, and you can leave as long as you are happy to do so. So radial shockwave, obviously this is again something that I'm very familiar with and most of us probably are familiar with, but it is the EMS are the inventor of radial shockwave therapy, and it's dedicated for practitioners kind of who specialize or use this within those chronic injuries, chronic tendon injuries. And that's certainly where my practice has changed the most, I would say, is that I would struggle to treat these patients previously. I wouldn't know what to do with them. That introduction and addition of shockwave therapy into this clinic has really enhanced what we can do with. So there is unrivaled performance, and there is unrivaled performance with this unit compared to any of the other units. That's not within EMS, that's external. It will still continue to provide you the highest level of energy that is available from any radial device, from the new handpieces. it gets improved patient-centered treatment. So the idea is that obviously we want them increasing compliance and recovery. But I've just generally found that with the Doloclast and the new device, it's a lot more user-friendly. There's buttons on the handpiece, which allows us to increase the pressure on the bar from sitting down, so we haven't got to reach over to the unit. I just think that it's a really nice new piece of kit. It's portable. There's no external compressor, so it can just be moved from site to site. Actually, mine is in Llanelli at the moment with the Scarlett, so we can shift that back and forth. So it's a very, very good new radial device, and it hasn't compromised anything. We have got 2 internal compressors inside, so it's trying to get, it still provides the same level of energy, works really well. And obviously we have our Piezaclast. I don't use focused in clinic. It's something that I'm really generating a little bit more interest in now, but it is the highest energy that we can provide. I think with the positive and energy densities, at positive energy densities and the negative energy densities, you can get a maximum EFD of up to 0.8 with the intensity at 20. So it's very, very high, whereas the radial will give you an energy flux density max of at 4 bar 0.18. So we're probably, it depends, if you, the positive energy density is around about, I think it's 0.42, and that including the negative energy density, then that will give you about 0.8. So there's quite high energy densities at maximum. So this is the highest level of energy that we can provide with radial shockwave. And again, it's useful for those very stubborn, deep recalcitrant tendinopathies. So laser fundamentals. What is so special about this laser? And the big thing realistically is that the therapeutic window for laser is between 650 nanometers and 1350 nanometers. And this laser falls at 905. So this is 905 nanometers. And this is a magic number a little bit, because this is where there is the least amount of absorption by other tissues in your body. So your hemoglobin doesn't absorb as much of the light. Your melanin doesn't absorb as much as the laser. The water isn't absorbing much of the laser. So the laser has got all of the energy focused onto the tissue that it needs to. So they're not absorbed by anything else, so there's no energy wasted. And the other thing that is quite, so again, because it's not absorbed, it means it can penetrate further. Now, the other thing that is useful about this is that obviously the peak power is 300 watts, which is the highest out on the market as far as I'm aware at the moment. So, sorry, let me get that one done. Now, this laser is pulsed. It is a pulse laser. It is not a continuous laser. And the modulation element, as well as the frequencies and the different types of frequencies, is what means that it doesn't burn your patients. So with the high energies, if it was continual, that would be a hot laser. But because it's pulsed, and you can obviously with the settings, it's the frequency and the modulation can be changed to suit. But these are all preset on the machine depending on your goal. But that's why it doesn't burn the patients. It does if you're over, it can be a little bit burny if you've got to go over tattoos. So we advise you not to go over tattoos. And in patients with kind of dark brown skin, that also isn't ideal. So there is a hypersensitive setting on the unit. And that's what we would use in those cases. So if there's somebody with a sleeve or a tattoo over their shoulder, and that you've got super spin, we just change that then to a hypersensitive setting on the machine. So, as I said, 905, the right wavelength, it is the magic number. There was a study, Mezawa et al., and this is an old study, but it was essentially showing the reasons why we do 3 minutes of radiation. So 3 minutes of irradiation was enough to give the maximum change, a reduction in nociception for a cat's tongue. And it was a thermal, they used to pretty much just burn the cat's tongue and 3 minutes of laser radiation was enough to reduce down the nociceptive input. And that is why we leave it. That's why we leave it for 3 minutes. What that study showed was, if we leave it on there for 3 minutes, all the way up to 10 minutes, there was no greater improvement from 3 minutes to 10 minutes. So that's why we do 3 minutes. It's to make it time efficient. And then we also have this suppression of acute inflammation. Again, as we said, with that prostaglandin E2 reduction in those acute cases. Again, that was by Bjordal et al. So the 905 wavelength, providing you with the ideal therapeutic effects for acute inflammation and acute inflammatory changes. That is what we want to do with this laser, is that we want to be able to, the wavelength is specific for musculoskeletal injuries, and it's very effective for those acute musculoskeletal injuries, and it doesn't burn, so you don't lose any energy, which means that we can get a little bit depth and penetration, and it doesn't then create any heat, so there's no kind of effect on other tissues within the body. So it's doing exactly what we need it to. So again, yeah, there we go. That explains then the intensities and kind of the penetration, as to the depth of penetration can go up to 120 millimeters, that's 12 centimeters with the light. And that's just having that therapeutic effect that is deep into the tissues. The short pulse duration of 100 nanoseconds is why we don't burn. So it's that, again, that frequencies and the pulse, the fact that it's not a continual laser. So shockwave therapy, this is again something that most of us would be familiar with. In physics, a shockwave is a type of propagating wave that moves faster than the local speed of sound. So in day-to-day life, we can see shockwaves being produced when an airplane breaks the sound barrier. Earthquakes, for example, produce primary and secondary shockwaves. Thunder, kind of those type of things, explosions, they are all shockwaves. And they are essentially something that occurs naturally in nature. And unfortunately, we discovered shockwaves in World War I, really, when soldiers were presenting into medical situations with all these internal traumas, lung pathologies and abdominal pathologies with no external signs of trauma. So that's essentially why we were aware of shockwaves and the potential damages. Obviously, they then went on to animal testing later on to see if there's any low, kind of what side effects would occur if it was done over the abdomen, over the brain, and there was low level side effects in the lung, the abdomen and the brain. So, you know, it's been something that has been developing over the years and very kind of been developing from Germans. The Germans then developed it to become a destruction tool. Essentially, they used it to break down ceramics in water baths. And then in the 90s, it was more interest in musculoskeletal conditions. And that's then where all the research has come from. And obviously, lithotripsy is one of the first, kind of 1971. It was a lithotripter. It was the first non-contact disintegration of a kidney stone in Germany with a lithotripter. So only lithotripter. But that's essentially focused again on lithotripsy, which is different to our radial devices. And that radial device has been ongoing for over 20 years, and that's where we are now. So what are therapeutic shockwaves? As I said, we have different types. We have intracorporeal shockwaves, which is your lithotripsy, and that is very much in a urology department. That's outside of our scope a little bit in clinic. And then we have shockwave therapy and extracorporeal shockwave therapy, and that is divided into focused and radial, as we've discussed. Now, radial shockwaves are where we would predominantly, that's what most people use. Your focused shockwaves can go into your extracorporeal, which is your lithotripsy. So lithotripsy is focused, and then you have your other focused, which is shockwave therapy, which is your Piezoklast device. And again, these are used and isolated. The focused and the radial are used very much in orthopedic kind of environments and physiotherapy environments and chiropractic environments and osteopathy environments. So they're used across the board with conservative management options. whereas the lithotripsy and the extracorporeal shockwave, that is a little bit, in hospitals for your kidney stones, etc. So fundamentals. With radial shockwave, we can, the idea is that 1 bar will get you 1 centimeter of penetration. So 4 bar can get up to 4 centimeters of penetration. And a shockwave is characterized by a few things. It needs to have a very high positive peak pressure. It has to have a rapid rise time. Then we have a negative energy density, and this all occurs over a very short period of time. So there's 4 key points that define a shockwave. So as you can see in that kind of graph on the right-hand side of the screen there, the positive energy density is the phase where we create compression through the tissue. And then we have this negative energy density, which is where the cavitation is produced. And that cavitation is essential. That cavitation produces secondary shockwaves. When that cavitation bursts, it produces more shockwaves, which then create more of a cascade of events, mechanical stimulus, and that's how we get the outcomes that we do. So this is a shockwave. That is how a single shockwave looks on, let me do that again. So this is how a single shockwave looks on shadowography imaging. As you can see, let's do it one more. As you can see here, that's your positive energy density, and that bubbles being produced is your negative energy density. So here's your compression phase, here's your tensile phase, and there's your secondary shockwaves. There you go. And see the bubbles, cavitations, secondary shockwaves lead into a mechanical stimulus. And what does this do? So this is this mechanical effect. It's the red hot chili peppers, essentially, or red chili peppers, sorry, copyright for the red hot chili peppers. So researchers, this is this experience where if you bite onto a chili and it really hurts initially, and then it all of a sudden just becomes numb. And that's obviously in a chili due to the capsaicin. It's because the C nerve fibers have become overstimulated. And this is what shockwave does, is that we activate the C nerve fibers, and that then reduces the substance P. So it's basically, so it releases the specific substance P in the tissue as well as the spinal cord. And this substance is responsible for the slight discomfort during and after shockwave treatment. So however, when you prolong that substance P activation, the C nerve fibers are incapable of releasing substance P for some time. So it reduces that neurotransmitter essentially, and it inhibits the neurotransmitter from leading to that first order neuron, which then gets to the brain, to the spinal cord. There's a second order neuron, and that is the site that we get that neurogenic reduction, neurogenic inflammatory reduction. So it also, at the site, we reduce substance P, and at the spinal cord, we reduce substance P. And that is those neurogenic, that local substance P reduction and that neurogenic anti-inflammatory response that we're used to. So dose dependent, and this is quite interesting actually, and a lot of research and clinical evidence, and anecdotally we can say that the higher energies that we can put into the device and into the patient, the better the outcomes we would get. So clinical research shows that the therapeutic effects are linked to the level of cavitation produced, and we know that our devices and the EMS will produce cavitation in the tissue. When we show you those images, it's in water and it's shadowography, and a lot of people think, well, okay, that's well and good, it's happening in water, but what about my tissue? In the tendon, for example, 80% of the tendon weight is water. A dry weight of a tendon is 20%. If there is no water, it weighs 20% of what it should do. So it will create a mechanical vibration and it will travel through those tissues. And that's kind of one of the reasons why it's so effective and it doesn't lose energy. So as you can see, at 4 bar, the energy now is same 0.18. It's not compromised at all. And it doesn't really lose energy until you get up to around about 20 hertz. So it's consistently at around about 0.18. But even at 25 hertz, which is the new kind of maximum frequencies that it can get delivered to, we're able to produce 0.14, which is only about a 20% reduction in energy. Now at 20 hertz, for example, we are closer to 0.16, 0.17 EFDs. So realistically, we're not getting a great deal of energy lost as we go up to the frequencies. And what we find clinically is that if you increase the frequencies, you can get a little bit more tolerance from the patient. So just worth considering, if you're not compromising a great deal of energy into the tissue from a treatment perspective, can we increase the frequencies just to make it a little bit more tolerable for them? But ultimately, bench studies demonstrate that dollar class radial shockwave device delivers up to 200% more energy density than competing devices at 15 hertz and above. So the energy is consistently higher compared to some competitors. And again, we're producing significantly more cavitation than competitors as well. And as we said, that cavitation is essential for the mechanical effects. This is your focus. So again, very similar in terms of that positive peak energy density, peak pressures, positive energy density, negative energy density. It's just a little bit different on how the cavitation is produced. And it's also different in terms of the shock wave itself is different. It's not as smooth. And this obviously doesn't have an external compressor. It's generated by electricity. So it's a piezo-class rather than looking at compression or air compression, anything like that. There's all kind of piezo-class is focused, is delivered differently. And this is how this one looks. So as you shockwave becomes a little bit more focused as it enters the tissue, and then the cavitation occurs further from the applicator site. So the one thing that I should say is that the key difference in the energy or the wave with shockwave focused versus radial radiates, it's like a torchlight, and then focus becomes more pinpoint as it leaves. So they are the two main characteristics, and as you can see, difference in the cavitation is completely different. The radial device is closer to the applicator where the cavitation is produced, whereas focused is closer into the tissue. So maybe for those deeper structures, if you felt that the cavitation needed to occur deeper into the tissue, focused may be your first choice option. And again, talking about the high energies, high cavity, and then getting better outcomes really because the higher energy is being delivered. So yeah, studies demonstrate that when you combine the positive and negative energy densities is up to 2 times higher than the competition, which means that the total energy density is greater with the piezo-class than best in class competition. So again, it's just being able to deliver those maximum energies at during the peak positive pressures and the negative energy density as well. So treating with GDT. I think firstly what we would do is just kind of get a pain scale to see how they are, how the patient is from 0 to 10, mark on here where you are. How would you rate that pain on an average from day to day or over the week? And that's up to you how you do that. But I think it's really important to get a baseline measure. If we can get a baseline measure, then we can say, okay, let's see how we can improve this and let's see how this goes. Now, you haven't got to assess them every time because it can sort of reinforce your pain, but certainly or reinforce the pain is still there if you ask them every week, can you give us a score out of 10? Whereas actually, maybe at the end of the 3 sessions, you could go, or 6 sessions or whatever it is, you can go, how is it now? How is it feeling? Mark out of 10 where you are, how much progress have we made? What I sometimes use is I use a stick and I kind of go, when you come in, you were down here, where you want to be is here, where are you along that journey? And that's something that we use in clinic just to kind of pinpoint what we need to be doing or see where they are along that process. So pain chronicity, and this is really important as to what you would choose and what device you would choose. But in the acute stages, we would tend to be dollar class laser only. In those subacute from 4 weeks onwards, that's when we can use the GDT, and that's when the GDT comes into its own. So we can really combine the shockwave with the laser from 4 weeks onwards. And we used to say that with the chronic time frames, that's when shockwave would be, so 3 months, 6 months. Now with the GDT, it allows us to things and see patients a little bit earlier. I would just a range of motion. So with the shoulder, check all of these different ranges, check into flexion, abduction, extension, see which, mark that out of 10 as well, where the pain is and what level the pain's at. We've actually got a little electronic goniometer, which we ask the patients to hold, go into a neutral, come up, see how much external rotation they have. Little things like that are quite nice. It's an electronic way of, so it's very specific. And that's quite a nice way that we do that in clinic. But then again, what the idea here is that when it comes to this reassess stage on stage 6, is that we can go, okay, let's see where we are. Let's actually see how this first set of data compares to your last set of data. And it just reinforces those improvements to you and to the patient. So the decision tree. How long have you been suffering from pain? Less than a month? If it's acute, are there any contraindications to treatment with Dollar-Class laser? We'll go through the contraindications in a bit. Yes, then we recommend that you find another treatment. If no, however, then treat with a Dollar-Class laser on indication or action mode. So if it's longer than a month or subacute and chronic, are there any contraindications with the Dollar-Class laser or Dollar-Class radial or focus devices? And if there is, then obviously we would say, let's find another product or another way to treat you. If not, how do you want your results to be? Do you want to go down your standard treatment with just Dollar-Class shockwaves alone, if it's suitable with the chronic cases? If you want to combine, if you're restricted with time and you only have 5 minutes in between patients, let's do 3 minutes of GDT, wait for 5 minutes, and then apply your shockwaves. However, if you have a little bit more time, you can do laser, rehab, not heavy load, but get some movements, just get some isometrics in, and then we can shockwave again. So there's ways that we can do that. The idea would be if we book you in for a full kind of hour, or maybe a little bit longer, an hour and a half, or you can do your laser, then we can go up and do some rehab if you have the facilities to do so, and then we apply the shockwave again. And that's just getting a little bit more tolerance to the laser, to the shockwave, allows us to apply more energies, which should, in theory, give us better outcomes. And that's what all the research is saying. The more energy, the better outcomes that we're getting. And mainly, pain is the contributing factor as to why we can't get those energies. So contraindications checklist. There's very little with the laser. Don't go over areas which are affected by neoplasia. Treating in pregnant women, again, this is one of those ones where certainly over the fetus, I would say no. If you go in, if I were to apply it to a plantar fascia in a pregnant woman, is it likely to affect the fetus or the mother in a negative way? Very unlikely. However, it is a direct contraindication just in case anything occurs during the pregnancy. And the only thing that they've done different is laser. It's going to fall onto you as a as responsible or potentially responsible. The other reason as well is that obviously ligamentous laxity and tissue laxity changes throughout pregnancy, so it may impact negatively on that. And obviously we would say let's not treat over implanted electrical stimulators. From a shockwave perspective, as we said, over air-filled regions, so any pre-ruptured tendons is a no-go just because it's more susceptible to rupture. Treatment of pregnant women, treatment of patients under the age of 18, except for Osgood-Schlatter's, as we discussed. Treatment with blood clotting disorders, and treatment of patients with oral anticoagulants, and treatment of tissue with local tumors, local bacterial and viral infections as well. So we don't want to go over those areas. And we would also say stay away from patients that have had a cortisone injection within the last 6 weeks, just because, again, it's potentially more susceptible to tearing or trauma during those first 6 weeks. So again, that is how we would then do your step 1 and step 2 with the high-powered laser initially, and then followed by radial shockwave or focused shockwave therapy. So you then obviously encourage everybody to take a patient-centered approach and recognize that patients want to be involved with their recovery, recognize that every patient is different. So I may need something completely different to MC. MC may need a different approach to myself. And it's just those little things that we would kind of look at, and obviously maybe let them know what to expect a little bit. This is one of the things that I would say with the shockwave, because it can be so acute and it can kind of take your breath away a little bit when you have that first impulse. put it onto them, let them know what it sounds like, let them know what it feels like, let them kind of experience it in a non-painful area first, just to get them used to that noise, that environment, and then see how it goes. Obviously, set expectations. This is a big one that I think I previously and used to fall short on. Was my expectations with patients would be miraculously recovered. But tendinopathy and tendon changes are long-term changes. They can take up to 12 months. So realistically, if you're seeing 40–50% improvement after 3 sessions, that's amazing changes. Don't expect them to be miraculously recovered after 3 sessions. But then maybe after the 6 sessions, that's when we can go, wow, that's brilliant. You know, that's 12 weeks, 6 sessions in 12 weeks that you've done so well. That is where we would say that's where our final kind of expectations lie, is in that second set or second block of 3. That's where I see the majority of the changes. So set those expectations of, you know, to kind of treat how long the thing is going to last, how long is the treatment's going to last, what the pain response is going to be like. Will it be sore after treatment? Will it feel better after treatment? So just speak to your patients about that. And this is something that, you know, as practitioners, we would all do. Then obviously we use the Doll-Class high power laser. So we have the laser handpiece. There's a lovely new interface, which is all touch screen. And then we have an emergency stop button in the situations. We have glasses that we would wear during the treatments. And this is for a pair for yourself and for the patient. And they're lovely kind of dash-in glasses here, which are there. So they look lovely for you to wear. We put them on, and we obviously that protects your eyes and the patient's eyes, so it's just the safety element of it. Now, these are your indication screens, and you have the choice, as we said, of going manual with the actually holding the laser itself, or you can do it with the automatic arm. There is a tutorial screen as well, which shows you how to do it in whichever setting you choose. And then it goes to the ready screen. There's a warning screen, so there's a reminder to put on your safety glasses. The laser is ready, and then the treatment is ongoing. So it depends on, obviously, the setting, the action, the indication that you choose as to the length of time for that treatment. And your new radial shockwave device. So whereas the pressures are the same, 1 bar up to, actually, I think the Doll-Class, the Master Touch used to be 1.5 bar, so this can go down to 1 bar, and it can go up to 4 bar as well. Same energies delivered, 0.18 EFDs. This time we have increased frequency though, so we can get up to 25 hertz rather than 20 hertz. There is analgesic modes, there is ramp up modes, there is burst modes. There's all these different modes in this machine, which the analgesic mode will do a preset of 1,000 impulses at 25 hertz just to get a little bit of a hyper stimulus into the area that you're treating. The ramp up, there's 2 settings there. Setting 1 will just go up by 0.5 bar throughout the treatment and stay there. Setting 2 will go all the way up to 4 bar for as long as there's impulses to go through. Burst mode, there's a random allocation of increased frequencies, so you don't get the tissue used to a stimulus. So again, that's just quite another useful tool, that if you don't want the patient to get used to the stimulus, you can just do either random bursts, or you can actually control the trigger to provide a burst of energy as well. Oh, here you go. Sorry, I just explained these. You have different applicators as well now. These have a simple 2-screw mechanism. So whereas the Master Touch used to kind of be screw in for quite a while, this one, 2 turns, all fixed in. You get the 15 mil, and we have a new applicator head now, which isn't 36 millimeters. It is now 40 millimeters, so a little bit larger. Very useful for your myofascial, large areas, large tissues. Also quite useful for kind of medial tibial stress syndromes. So if the patient can't tolerate the 15 mil over the bone, the 40 mil and the 36 millimeter heads, they're very useful over those areas, just to get some energy into it and some triggers. You have your trigger points, your deep tendinopathy, so with a focused kind of, there's a concave area rather than a convex area. So all of these are your different applicator choices for different situations. There's a new handpiece. Personally, I hold mine like a pencil. So I go into pencil grip. It's nice that I can use the other hand then to control the ups and downs. You use it as you feel comfortable, realistically, but there's nice ways and a nice new handpiece, and the buttons on there are a really nice addition and much more user-friendly than trying to reach over and trying to drag over. There's been a few times where I've been treating patients and trying to press the up button on the master touchscreen and immediately shot everyone straight up to 4 bar, which hasn't been ideal. So that's kind of now a thing of the past with the new dollar class, the radial device. And then we've got your focus shockwaves. Again, these are different. The intensity ranges from 1 to 20. You can choose the counter display to count down or to count up, depending on how many impulses you want to put in. The frequencies go from 1 to 8 hertz, and the settings are completely different for that. And as I said earlier, there's a silicone head on these, and if you want to target more superficial areas, then that tends to be with a deeper silicone head. If we have a deeper silicone head, a lot of the energy will be going through the silicone, and the cavitation will occur then deep, more superficial into the tissue, but same distance away from obviously the applicator site. Whereas if you do a really thin kind of silicone head, all of that energy is then going through the tissue and straight into the tissue, and it means that there's a deeper penetration and you can affect deeper tissues that way. We then go through our rehab, and the rehab is, for me, the essential part. I think that, as we know, in combination, shockwave plus rehab has always been superior. And we're finding exactly the same thing in the GDT in clinic. We shockwave a patient, or if we laser a patient, we shockwave a patient, and we rehab it. That's where we're going to get better outcomes. It's always when we're going to get better outcomes. And then we would follow up, as we said, we can go through your range of motion assessments again. You can do your VISA-A scores, you can do your VAS, so you can look at your scores out of 10 for your pain, and then just see. I think patients are very, very good at word of mouth that spreads, and if they get better immediately through this modality, then they're going to tell their friends, and friends are going to come in, and it's a very good way that if you treat your patients. We were always told in university, if we look after the patient's business and everything else looks after itself. But the GDT is very, very useful for that. And more importantly, evidence. Pedro is huge. So the physiotherapy evidence database is your Pedro database, and it is freely available. There's over 50,000 randomized control RCTs in there. And where are we with that? So we've got 45 studies, and 35 of them are using Swiss dollar class devices. 80% of those have achieved positive outcomes, and in that 20% that didn't achieve positive outcomes, you're looking at that being because there wasn't significant kind of energies delivered into the tissue during that. So there are some, this is backed by evidence, and again, we are looking over the forthcoming years and months to develop more evidence specifically onto the GDT, and to see this combination and how this combined effect is beneficial in clinical practice and as well as in a RCT setting. So this is all ongoing, but from a perspective of previous research with shockwave therapy, this is where we're at. There is some preliminary evidence which has been done by Christoph Schmitz, which is suggesting that in the early phases, if we wait for 5 minutes in between laser to shockwave, we can get around about a maximum of 50% increase in energy being delivered to your tissue. Whereas if we wait for an hour, there is a chance that we can increase the energy being delivered into the tissue by 100%. So we can double the energy that is being delivered. That's really good. But again, if we can get better energy, higher energies into the tissue, we can get better outcomes for these patients. And that's what the GDT's aim is in combined approach. That's it from me. I see that there's 2 questions there. MC, I'm happy to answer them if need be.
Thank you, Daniel, for providing this great presentation and how the GDT can improve the daily practice by combining laser therapy and shockwave therapy. Yes, we have 2 questions from our participants. From Esther, who is curious, what diagnosis should I treat with focused head of power and peace? Is it for bone problems?
The focused head of the power handpiece is going to be those very deep kind of pathologies, I would say. It again becomes a little bit more focused because it's that concave applicator. So it'll become a little bit more focused as it goes into the tissue. And because you're using the power handpiece, you're going to get significantly more energy into it anyway. So this is going to be, yeah, it's going to be quite interesting to see how much they can tolerate, because those energies are going to be higher. With the power handpiece, personally, I don't think that you necessarily need that focused head. Not obviously all the time, you will in certain circumstances. But for the focused head, I would look at the greater trochanteric pain syndromes, those type of things, the deeper kind of structures that we want to be looking at. Maybe even your proximal hamstring tendinopathies, and even in large bodybuilders, those type of things, we can look at those. I mean, you can get up to 0.4 EFDs with that. So you're doubling what you can get in the standard radial devices. So yeah, I think that you would be looking at those deeper, really deep pathologies with that focused head on the power handpiece, really.
Okay, thank you. Thank you.
No problem.
And she has also an interest in knowing how to treat sports teenagers as well. Do you have some tips and tricks?
Yeah, so I'm assuming that's going to be kind of your Osgood Schlatters patients, because that's your teenagers, teenagers in sport, and that's predominantly what they come in with. I think because teenagers is a complete contraindication when it comes to shockwave therapy, you're limited with what we can do with those. Not necessarily with the laser. You can definitely do laser over, with Sever's disease and things like that. However, when it comes to your shockwave, I think that because there's no evidence to say that Sever's disease is safe to treat, then we can't necessarily say that that's safe to treat. Whereas laser is completely fine. There's no issues to why we can't do that.
So you would use other techniques for
100%, yes, absolutely. So then that's when it comes down to your clinical expertise and what skill set you have as a practitioner. But yeah, absolutely, the laser would be useful. The shockwave is obviously not available for most cases and most diagnoses, except for Osgood Schlatters. But then you can use your clinical guidance and your clinical expertise then to come up with your plan. This is just a nice adjunct. That's what I would say, is that the laser is an adjunct and the shockwave is an adjunct to your standard care. And it's a very, very good adjunct. That's the difference. When shockwave isn't available, and this comes down to that decision tree, is that if shockwave is contraindicated or laser is contraindicated, then you have to find another treatment modality.
Okay, thank you, Daniel.
No problem.
The next question, thank you for your great presentation. I'd like to ask about the contraindication of laser treatment regarding pregnancy. Is it an absolute contraindication or relative one? Does this condition apply in all timeline of pregnancy? Is it still a contraindication if the treatment area is far from body trunk, e.g. risk for coupled senile syndrome treatment? If it's still possible, should the treatment be reduced?
Yeah, so this is really interesting. So from a company perspective, EMS will say that yes, this is a direct contraindication, because they have to. They're looking out for themselves, and they have to protect themselves as a manufacturer. The big idea is, as clinicians, it comes down to, if anything went wrong during that pregnancy, where is the litigation? Where is the liability? And the liability could be on you as a practitioner. And that's one of the reasons why I consider it, majority of the time, just it's not even worth the risk. If there was anything that went wrong and the fingers pointed at you, you are susceptible to being on the end of a lawsuit. And that's my biggest concern with treating pregnancies. I do also consider the fact that potentially there's going to be some laxity within the joints. There's going to be some laxity throughout the tendons. I just think that there's a little bit more going on than just a standard kind of, what we've got to think about is that pregnancy isn't an illness. It's not an illness. It's not a medical condition. It is a state. It's a pregnant state, and your body goes through changes. But it's just whether or not is there other ways that we can manage them if there is a perceived risk. I think realistically, yes, we would definitely avoid doing it over the fetus and over the abdomen or every time. It comes down to you as a professional as to whether or not, and the patient, if you want to discuss that with the patient, that comes down to you and them. But from a perspective of a direct contraindication, we would say that yes, it is. But it's one of those where if you were seen to deviate and go off piece a little bit, unfortunately, that's down to you then, if anything went wrong. And that's the kind of the most way that's the best way I can put that, is that it's down as a contraindication because if anything went wrong, it can't fall back onto the manufacturer. And it unfortunately the buck kind of stops with you as a practitioner, and that's the kind of the hard truth with it, I think. But again, from a perspective of, can I see? I'm going to completely contradict myself here, but can I see it? If I did laser on the plantar fascia, is it going to affect the fetus? I really don't think it will. But again, that's not medically, we can't say that it doesn't. And that's the difference. Whereas, for example, shockwave in Osgood-Schlatters disease, there's been research to say that it's safe and there's no negative side effects in a study in Germany. So that's how we can use it on those patients. Whereas there's been no evidence to say that laser is safe for pregnancy. And it's probably because of ethics. They can't do that study. I hope that helps. And I hope that's kind of okay.
That's clear. That's clear, Daniel. It's always, it's true. It's always under the responsibility of a practitioner, especially talking about contraindications such as pregnancy. Yeah. So thank you for answering this tricky question. Another question, last question from Tinny. If a patient suffering from pain and gets intervention pain management injection for inflammation, when can we add shockwave therapy for regenerative therapy?
I'm assuming this is probably a knee case, Tinny, I think. If it's a knee case, we would just leave six weeks. That's all. Again, if it's a steroid injection or if it's an anti-inflammatory injection, we'd leave 6 weeks in between commencing. I tend to actually be a little bit more cautious with the lower limb. I leave 8 weeks with the lower limb just because it's weight bearing, and I leave 6 weeks for the upper limb. There has been discussions amongst us as trainers as to whether or not we should probably leave for 10 weeks as a rule, just a consistent rule. But,
just to be on the safe side?
Yeah, but the current guidance is 6 weeks for across the board. I leave 8 weeks for lower limb just to give it that extra couple of weeks, and 6 weeks for the upper limb. But 6 weeks is a minimum.
Okay. Thank you very much, Daniel.
No problem at all.
That was the last question. Any additional question? This is your time. This is your time. Otherwise, we'll keep you informed for the next webinars. No other questions so far. So I guess we will close the session now. Thank you, everyone, for participating in this refresh about the GDT. Thank you again, Daniel. That's always a pleasure.
No, thank you. Thank you for having me.
Thank you, and see you next time online. We keep you informed by email and on our social media network via Facebook about the next online sessions. Thank you again, and have a great weekend. Thank you, Daniel, and see you soon. Bye-bye, everyone. Bye-bye.